Good morning. PT on Ice Daily Show brought to you by the Institute of Clinical Excellence. How are you this Clinical Tuesday? I hope you are feeling festive. My name is Dr. Lindsay Huey. I am the lead faculty for extremity management, along with Dr. Mark Gallant and Dr. Eric Chicones. So pumped to be with you today. Today, on this Clinical Tuesday, we will be talking about taking the BS out of ITBS. So we'll chat some untrue and outdated narratives surrounding the iliotibial band. In fact, iliotibial band syndrome, even that name is outdated. And then we'll review overall patient presentation, debunk some myths, and then finally summarize what's best treatment for the IT band. But of course, before we do, let's just review some courses that are coming up. January is stocked with live courses. Pretty much every weekend starting in 2022, we have a course coming to you somewhere across the United States. So check us out on ptonice.com. But we do kick it off January 8th with modern management of the older adult. And then I will be in Georgia January 15th, the following weekend, with extremity management. So if you are unable to hop in 2021, please join us in the new year. I'll be with Monique at Onward Atlanta. It should be so beautiful. And then January 15th, we have modern management again and lumbar spine management. And through the end of January, we'll see modern management coming up again, and then clinical management of the fitness athlete. Literally, I could just keep listing them because almost every weekend is stacked. We're so jazzed for 2022. There's a lot coming at you. For online courses, please check us out as well on ptonice.com. I know some courses just started and some are coming up in the new year. So we would really love you to join us, both live and online. So thanks for the opportunity to share that with you a little bit. So going back to today's topic, taking the BS out of ITBS. So first off, I want you to be thinking as I go through this talk is to stretch or not to stretch, to roll or not to roll. That is the question. And I hope you'll be able to answer this question for yourselves by the end of this podcast. So Paul R. Geisler in August 2021 came out with this awesome current clinical concepts out of the Journal of Athletic Training. And it really helps illuminate the most up-to-date evidence-based narrative of treating IT band syndrome. And really, most recently, the term has changed, that it's not ITBS, so even that title is BS, it's iliotibial band impingement syndrome. So I hope to share with you and help you kind of understand why that name changed today. But let's first just discuss the IT band because it's anatomically complex. It's often referred to as the deltoid of the hip because much of the glute max fibers attach and then all of the tensor fasciae lata fibers go into that. Unlike the deltoid at the shoulder, it works mainly in a closed kinetic chain environment. It connects the pelvis hip to the knee, running laterally along that iliac crest to Gerdy's tubercle. It is part fascial thickening, part ligament, part tendon. So it's a pretty complex structure composed mainly of type 1 collagen with some elastin. So it's mostly a vascular tissue. Because it is a fascial structure, it has this amazing ability to adapt and transfer mechanical energy along it. So it's a really fan-freaking-tastic mechanical force distributor. It acts to eccentrically stabilize that lateral hip and knee in closed kinetic chain activities such as walking, running, landing from a jump. But it really brings a lot of rotary and anterior stability to that tibiofemoral joint. So a lot of this, I know if you're a PT, athletic trainer, listening, orthopedic doc, you know all of this. Much of this is just a review. It's also responsible in regards to other actions, hip flexion, extension, abduction, and external rotation and medial rotation when it works with the glute max and TFL connections. So as you know, as PTs or humans treating patients with IT band issues, what we typically see with these patients is we see this sudden spike in training volume, whether it's running, biking, rowing, something that has that repetitive flexion and extension. Maybe someone recently started hill training or doing banked running. These are some commonalities you'll find in that patient profile history or report from the patient. They'll often also report pain with squatting and or going down steps. And then there is this psychosocial component that we see a lot too, where there's this fear of this lateral knee pain because it can come on pretty quickly and be pretty upsetting, especially if it's that endurance athlete or competitive athlete. In our exam, what we'll typically find, so again, all of this is really reviewed to complete that clinical picture, is that we'll have tenderness palpation at that lateral femoral epicondyle. Pain will often be produced with squatting or stair climbing and during the activity that's important to that patient, right? Running, rowing, cycling. They will have hip abductor and external rotator weakness and or fatigue, which won't come on until further into their activity. Usually you need to kind of test 20 to 30 minutes into that activity and or what that patient specifically reports, whatever time period onset comes on, whether it's before then or a little bit after. But that 20 to 30 minutes seems to be a sweet spot to bring out that fatigue in the musculature. And when I say fatigue, it's a mix of like neuromuscular reactivity and then in that frontal plane, so they kind of lose sagittal plane control and then start drifting. And that happens because of lack of endurance and or control over time that is lost. Sometimes we'll even see a presence of some pronation, so down further in the chain. On exam, we definitely will look at sport-specific biomechanic contributions, right? If our cyclist or runner's really falling into a lot of hip adduction, femoral internal rotation, we're going to look at that and we're going to intervene. So all these things, I know, again, aren't news. What I'd love to share is what we've thought about IT band in the past and now what an updated evidence-based view of it is, because this really influences where our treatment is. And we see a lot of variability in treating people that have this patient profile that I just explained subjectively and objectively. If you go to clinics across the country like we do teaching at ICE, you'll see a lot of variability in what is being done for their treatment. And I think it really starts because of the narrative being a little bit confusing, and especially if we're holding on to that older, less evidence-based narrative. So here's what we kind of thought all along the way, or that we were traditionally taught in PT school, that IT band inserts only on Gerdy's tubercle, often called the tibial ligament, that we had a positive Ober test because of a tight IT band, that when the IT band is tight, it's actually crossing over that lateral femoral epicondyle when you're going from flexion to extension, causing friction, and that when we compress, doing that provocative Noble test, compression at that lateral femoral condyle, as it moves from flexion to extension, we're really exposing that the bursa is irritated, secondary to, again, friction. But what an updated view based on cadaveric studies and just an overall inclusive evidence review, again, Geisler 2021, I'll post this later. This article is does an awesome job summarizing this. But what we know now is that due to the complexity of that iliotibial band insertion, is that there is no mechanical rollover. No rollover when transitioning from extension to flexion. When looking at cadaveric studies, the Ober test is not actually picking up on IT band tightness. That length of the IT band is literally not changing. Rather, there's glute med and glute minimus and lateral joint capsule tightness. That's what's limiting that passive femoral adduction motion. So from the cadaveric studies, we also know you just really cannot stretch the IT band. There are no manual therapy forces that can literally stretch this thing. Any anecdotal kind of relaxation changes that maybe you've noted personally in doing some self-treatment, or that you've noticed with patients, is most likely related to some mechanoreceptor stimulation in the fascia that induces some tone change in the muscle fiber connections. So consider that kind of like a nervous system response rather than changing tissue length. There is no bursa found in this area. Rather, it's an innervated fat pad between the IT band and the femoral epicondyle. So this is what's serving as that pain generator. So basically at that lateral synovial recess, the fat pad and the synovial fluid impinge. So this is more of a impingement, not friction. And then what we've kind of known, tried and true, is that inadequate hip muscle stamina results in that frontal plane femoral drift. But that is what's causing the fat pad impingement at that 20 degrees of knee flexion, not kind of a bursal irritation. So knowing this new narrative, here is how we will treat our humans with iliotibial band impingement syndrome. We don't want to treat the band, we want to treat that environment around the band. So that's really going to start with a lot of good neuromuscular re-ed to train the hip musculature to have kinematic control and strength. And this is based on level B evidence, but to really own that lumbopelvic unit and control. Then doing some loading, either lateral or front step-ups, and gradually increasing that load based on irritability, so that you can work on lower kinematic control, glutes, quads, hamstrings, while also working on training that femoral adduction and internal rotation to maintain. Thinking about not just strength, but endurance in this space, because these athletes have high repetitive motions. Using split squats for local quad and hamstring strengthening, that elevated split squat, that's a go-to. And then finally, doing some jumping rehab and running or cycling, whatever their sport is, but making them increase that demand of lower kinematic control. To fully rehab the IT band, you need to add in that as well. So kind of energy storage and release type things, and can the body control that femoral rotary drift, so that you can promote full return to sport without symptoms. Other techniques that based on clinical experience and expertise that I find being very helpful is, again, influencing the environment around the IT band. So doing some myofascial decompression, like cupping along the vastus lateralis, the glutes, and the TFL, but never really treating directly that IT band, but treating those structures around. Nothing hits that glute medius and minimus better than a dry needle, and so dry needling I find to be very effective, not only for helping with decreasing any tone that might be present, but helping with muscle activation. So what's awesome is doing that and then following it up with some load, and you'll often see dramatic changes in the ability to control using that intervention. So kind of based on this new narrative, I implore you to do no more stretching of the IT band, no more friction massage, no more strapping the IT band. This is not a friction issue, this is an impingement issue. Limit your modalities, no injections here, and based on kind of what the evidence says, not using corticosteroids if you're beyond that 14 days to control pain. This article, I really recommend, the Geisler 2021. It goes through very specific levels of rehab, 1 to 3, and bases on irritability. So if you're really interested in knowing what exercises are most appropriate, check that out. I kind of give you my top 5 exercises that we use in rehabbing this condition. But they really go from an open kinetic chain to closed kinetic chain progression that's really nice. So in summary, while the treatment for iliotibial band impingement syndrome may be overall simple, and some things you probably were already doing, the narratives around treating the condition aren't really as simple as we thought. And so I really want you to know and embrace the new updated narrative, and remember those go-to treatments of myofascial decompression, dry needling and/or dry needling the TFL, glutes, and vastus lateralis, adding in reactive neuromuscular re-education to control that femur and pelvis, doing whether it's the lateral step up or contralateral loaded step up, split squats, and then jumping, running, training. So those are those top 5 things that I would recommend in treating this condition to fully rehab that iliotibial band impingement syndrome. Would love for you to join us on the road at Extremity Management this year to discuss dosage specifically for this condition and just to experience some of these go-to treatments I just listed. Happy Clinical Tuesday and happy Christmas if you celebrate. I really wish you all moments of joy as you finish out 2021 in December, and cheers to 2022. Thank you for listening today. Bye-bye.
Hey, thanks for tuning in to the PT on Ice Daily Show. If you enjoyed this content, head on over to iTunes and leave us a review. And be sure to check us out on Facebook and Instagram at the Institute of Clinical Excellence. If you're interested in getting plugged into more ICE content on a weekly basis while earning CEUs from home, check out our virtual ICE online mentorship program at ptonice.com. While you're there, sign up for our Hump Day Hustling newsletter for a free email every Wednesday morning with our top 5 research articles and social media posts that we think are worth reading. Head over to ptonice.com and scroll to the bottom of the page to sign up.